Drug use and prevention from cradle to grave. Not one of my favorite chapters, but it's kind of fun. So let's go ahead and get started. And it's blue. Psychoactive drugs from birth to death. A fetus is exposed to heroin through the umbilical cord after an addicted mother shoots up. Of course, this happened in my own family. My great niece was a heroin addict, and she was pregnant, and she shot up and took opiates during her pregnancy. And of course, I talked about how destructive that's been for my great nephew. 14-year-old is offered MDMA at a party to get rolling. College student troubled by bulimia makes herself throw up 5 times a week. A young mother with 3 children hides in her room to smoke crack. 28-year-old IV methamphetamine user infects his girlfriend with HIV when having sex after using a contaminated needle. In one office, one worker is taking Klonopin to deal with the anxiety, while another takes Prozac to combat depression. A mother with grown children battles boredom and the empty nest syndrome by compulsively playing poker machines at the local casino. 50-year-old salesman on the road smokes and drinks to cope with his loneliness. 74-year-old with arthritis borrows hydrocodone from a neighbor to relieve the pain when he normally uses Aleve or ibuprofen or acetaminophen. Prevention and treatment throughout the life. Encourage pregnant mothers to attend prenatal care programs to teach them how drugs affect fetuses. Greater public scrutiny of parties, limiting the use of club drugs such as MDMA when people are rolling. Offering counseling on eating disorders in high schools and colleges so that you don't have to throw up all the time. Using outreach workers to encourage drug users to practice safe sex and use clean needles to prevent the transmission of HIV and hepatitis C while attempting to bring them into treatment. Doing an intervention to get a heavy drinking sales representative into an employee assistance program, also known as EAPs. Holding seminars to enlighten senior citizens about drug cross reactions. And that's the problem with the 74-year-old taking hydrocodone. He needs to check it out with his doctor to make sure that the hydrocodone won't interfere with any of his other medications. Each society has to decide how they want to attempt to prevent self-destructive drug use. Are they trying to prevent any use of psychoactive substances? Are they trying to ban just illicit drug use? Are they trying to limit the damage caused by use, abuse, and addiction? The United States and most other countries use a 3-tier approach to fight the destructive effects of psychoactive substances. Primary prevention, the program is a program to teach the skills to help the individual resist drug use. That would be your programs in elementary school and middle school. Secondary prevention, stopping the behavior wherever it starts. And then tertiary prevention is putting people through treatment and restoring them to health once they start using drugs. Governments work on prevention by reducing the supply of drugs through interdiction of drug supplies, legislating against the use of the drugs, and legal penalties for possession, use, and distribution. They reduce the demand by treatment of drug dependency and prevention through education, emotional development, moral growth, and individual and community activities. They reduce the harm that can be done to the community by promoting temperance, instituting needle exchange programs, supporting drug substitution programs, lessening the effects of alcohol, for example, promoting a designated driver program. Because I haven't had a drink since 1976, it seems like whenever I'm out with other individuals, I become the designated driver, which is okay with me because I'm not going to drink anyway. And of course, decriminalizing drug use is another way of doing that. Worldwide, the most widely used and successful programs have been supply reduction and temperance methods. Historically, in the United States, drinking and smuggling of spirits became part of the American fabric. It was easier for farmers on the frontier to ship their corn produce in the form of corn liquor than as grain. There was a lot of smuggling that was taking place prior to the United States becoming the United States, which is one of the reasons that there was conflict between the English government and their colony in the Americas, their colonies in the Americas. They would ship sugar by reducing it to rum. And of course, the farmers would ship their corn rather than trying to ship their corn over the mountains as corn, they would ship it as corn liquor, corn whiskey. However, with the influx of evangelical influences, there was a Methodist evangelical movement in the early 18th century, and then in the late 18th century, later in 18th century, there was a Baptist movement. These are two denominations of the Protestant church. Temperance became more acceptable as an alternative to heavy drinking and drunkenness. And both of these religions, even today, the Methodists and Baptists are well known for being abstainers of the use of alcohol. Such behavior became seen as a destructive, sinful, and immoral, and that's one of the reasons why the temperance movement was so strong in the United States, because of these two evangelical movements. An effort was made to get drinkers to switch from hard spirits to weaker beer, wine, and hard cider, so that they took away the heavy spirits, such as whiskey and rum, all the hard liquors. Tequila wasn't really used, wasn't an alcoholic beverage at that time, and vodka was too. It came from the east, from Russia and Eastern Europe. Hadn't really made it in Palinka and any of the other hard liquors. Dealing with the problem of alcohol consumption has been a continuing problem in the United States, fluctuating between moderation and forced abstinence. And of course, that was prohibition. Prohibition worked, but we'll see why they had to do away with it. As a country, use and the responsive movements have waxed and waned in 70-year cycles since the beginning of our history. In 1780, Dr. Benjamin Rush tried to legislate control over distilled spirits. Benjamin Rush was one of the signers of the Declaration of Independence. In 1850, a temperance movement supported replacing distilled spirits with more benign drinks, such as what we've mentioned before, beer, wine, and hard cider. This was the beginning of the temperance movement in the United States, trying to get people to stop drinking such hard liquors and staying drunk over an extended period of time. The temperance movement grew and grew and grew until 1920. The prohibition of alcohol was passed. 1990, the legal drinking age was raised to 21 nationwide. Before that, in many states, it was 18. I'm from Indiana. Indiana had the legal age was 21 in Indiana. But right next door in Ohio, the legal age was 18. So people would go from, we lived a county away from the Ohio border, and there were people that would make runs, beer runs to into Ohio when they were 18 and 19 years old. Of course, I went to college when I was 17, so I moved to the other side of the state. And that's not something that I practiced. Did the 18th Amendment work? This is an interesting question. It really all depends on your point of view. And there's lots of different points of view. From the point of view of law enforcement, it's one thing. From the medical point of view, it's something totally different. And this is more of a medical look at the 18th Amendment. 18th Amendment, of course, was prohibition of alcohol and manufacture of alcohol in the United States. Alcoholic psychosis admissions to state hospitals in New York and Massachusetts was cut nearly in half. Deaths due to cirrhosis of the liver were cut in half during Prohibition. There was less crime in general. There was less domestic violence. Even after Prohibition stopped, drinking levels remained low and didn't return to pre-Prohibition levels until the 1950s. Medical problems increased from unregulated manufacturing of alcohol, but the level never approached the medical problems that the nation experienced from the ethyl alcohol. If you remember manufacturing of alcohol, they were sometimes putting methanol in it. They were sometimes putting other toxic alcohols rather than ethanol. You can drink ethanol. There is a toxic level to it, but it's not going to poison. It's not going to kill you. Well, it can if you drink too much of it, of course. But if you drink methanol, you may go blind. Has an affinity for the optic nerve. You can go blind, and if you drink too much of it, you will die. And it wasn't nearly as much as ethanol. Some argue that Prohibition brought organized crime to the United States, but in reality, organized crime has been a part of the American underworld fabric since long before the 1920s. If you've ever seen Gangs of New York, lots of organized crime. Anytime you're dealing with isolated ethnic groups like what did we see? Irish gangs, and Italian gangs, and Polish gangs. Then you're going to see some degree of organized crime. Unfortunately, one problem with Prohibition was that because banning alcohol was touted as a cure for all of society's ills, treatment for alcohol addiction was cut. And of course, when Prohibition was repealed in 1933, there was a real serious problem because now there were no treatment centers. So treatment centers had all closed. Not all of them, of course, but most of them had closed due to the fact that they didn't have as many people that needed them. Some people claim that Prohibition was repealed because of the universal condemnation of the ban, but the real reason for its repeal was due to the need for tax revenues from its manufacture and use during the Great Depression. Pressure from wets and fatigue dealing with the continued argument did not hurt either. But it really had to do with the need for tax for the revenues from manufacture and drinking of alcohol. In 1962, before the Civil Rights Movement hit its stride and before the Vietnam War, only 2% of the American public used illicit drugs. However, with the aforementioned social movements and an era of civil disobedience streaking through the youth of the 60s and 70s, 31% of the population was using illicit drugs. Now you got to remember that I was one of these youths, but I was not using illicit drugs. In the 60s and 70s, I was in college running track, and then I immediately went into the military afterwards, so I wasn't one of those guys. During this time, knowledge-based programs were started to teach about pharmacological effects, causes of addiction, health effects of drug use, and legal penalties. And I can remember, I didn't really get any of that in college. I wanted to stay functional so that I could run track when I was in college. But when I was in the Air Force, we had seminars on pharmacological effects, causes of addiction, health effects of drug use, and legal penalties. I remember in my first permanent duty station, I was working in a hospital, and we had individuals that were in their teens. Now, in the military, of course, you can drink on base, but you can't drink off base if you're under 21. But we had a couple that came in, and she was like 19, and he was right around 21, and they were both alcoholics. They were drinking a lot, and we had to dry them out before we could send them for treatment. So we put them in the hospital is what we did, and of course we wouldn't let them go anywhere. So we had this couple that we were drying out. So we were feeding them all this all this information at the same time. It took with her, but it didn't take with him. And they broke up after they came back from treatment. She stayed sober, and he went back to drinking. There's no evidence that information alone causes changes in behavior, and as far as he was concerned, telling him about all this stuff was only going to make him feel tougher. And as far as she was concerned, she really didn't want to. It didn't. It did take with her, and it didn't take with him. Skill building and resiliency programs. As more research was being done, it was discovered that there were obvious psychological and developmental factors that predispose select individuals to drug use. Programs aimed at these individuals targeted social skills that might protect the individual from experimentation. Skills that address risk factors that might lead to drug abuse included general competency building, training in self-esteem, socially acceptable behavior, decision-making, self-assertion, problem-solving, and vocational skills, coping or resistance skills, developing self-reliance, confidence, and inner resources. These were classes that both of these individuals took when they were in treatment. And they were treated in separate facilities. I thought that was kind of interesting. They didn't want them to, they were afraid that they were feeding off of each other, and that's one of the reasons why they both drank so heavily. So one was we sent one to San Antonio, to Wilford Hall in San Antonio, and we sent the other one to, where was it? Beale Air Force Base in California, to their hospital. They had a treatment facility in California. There was one in California, there was one in Texas, and there was one in Florida, so Homestead, I think. Anyway, not important. Skill building and resiliency programs, reinforcing protective factors and resiliency, build on natural strengths that people already have available: optimism, empathy, insight, intellectual competence, self-esteem, direction of purpose in life, determination, supportive friends and family, opportunities to belong to meaningful groups. Address and reverse risk factors. Risk factors associated with future substance use disorders should be examined, with the focus being to seek strategies to minimize their development. Early aggressive oppositional disorder, poverty, if this is a problem, lack of parental supervision. Of course, these were two military people away from their parents. They were making some money. That's how they could afford a case of beer a night. They were each drinking a case of beer a night. She was drinking more expensive beer than he was. She was drinking foreign beer. I think it was Heineken. And he was drinking Coors. We did get Coors over there. Coors or Bud. There was no Bud Light at the time. Dysfunctional drug abusing peers, of course. And that's one of the reasons why we separated them. They were feeding off of each other's dysfunction. And when they came back, of course, they could do anything they want. They could move back in together. But she had stopped drinking, and he hadn't. And that broke them up. I hate to think that we were the cause of their romance ending, but that's the way it works. Support system development, endeavoring to reduce stress for students, which should decrease the need for drug and alcohol abuse. One of the reasons that they were drinking, it was because we were in an isolated place. We were in Lubbock, Texas. These two kids were from, where were they from? They were from Ohio or someplace. And that's why they got together, because they were both Ohioans, and they had known each other, but they knew of each other's high schools and that kind of thing. And that's why they paired up. But Lubbock, Texas is not a small city. It's relatively small, I guess, but it's isolated. There's nothing around it. You can't go anywhere else. Amarillo is like 150 miles north. Wichita Falls, 220 miles south or north east. Other than that, Dallas is 300 miles east. So they were they were pretty isolated as far as being able to go, and there was nothing there. I mean, it was up on the Llano Estacado, if you've ever heard about that. Changing the environment, one early target for concentration is the social and environmental influences that lead to drug use. Family values, of course, that wasn't a problem. Peer group values, this was a problem as far as they were concerned. And practices in schools. This is an attempt to get the entire neighborhood to take responsibility for preventing substance abuse by assessing the needs of the community, coordinating existing services, changing laws and public policy to reduce availability, increased funding for family, school, and community prevention, community-wide training and planning. Public health model for prevention sees addiction as a disease. The user is a genetically predisposed host. The environment contributes to the problem. The drug is introduced causing the disease. Prevention involves disrupting the relationship between one or more of these factors. Family approach. This approach sees addiction stemming from family dynamics. Families are bolstered through family support, skills training, therapy, and parenting programs. This approach focuses on the family rather than the environment. Supply reduction seeks to decrease drug abuse by reducing the availability of drugs and is the responsibility of state and local police departments, Department of Justice, and that includes the Federal Bureau of Investigation, the Bureau of Prisons, Immigration Naturalization Service, and Drug Informant Agencies. Enforcement agencies. Treasury Department gets involved as well. The ATF, the Alcohol, Tobacco, and Firearms Department, the Internal Revenue Service, and the Customs Service. Department of Transportation gets involved, as does the Department of Defense. The responsible agencies reduce drug supply by interdicting drug smugglers, manning law enforcement activities at border crossings, limiting the supply of precursor chemicals, disrupting criminal gangs and organized crime, passing more severe laws, increasing community police officers, disrupting money laundering and seizing assets, supporting local and state police in high-volume drug areas, supporting the anti-drug efforts of foreign countries, enacting treaties to work towards supply reduction. As far as limiting the supply of precursor chemicals, I was watching a news program the other day, and they were talking about the precursor chemicals that they use to make fentanyl, and they're having a problem controlling them in China because you can adjust the chemical structure of fentanyl. You get the same result, but it's a slightly different configuration. Now the problem is that, of course, you can say this is how you make fentanyl, and you can stop that type of chemical. But there are other chemicals that are very similar to that you can't stop. You can't just say you can't make this stuff anymore because it's used for different pharmaceuticals. It's used for industrial waste management. It's used for a lot of different things. So you can't just say that you can't make this stuff anymore. You can say no more use of this chemical structure, but you can't get rid of all the chemical structures, and that's a problem they're having in China. Drug laws in the United States have evolved to curtail the supply and use of illicit drugs. Long prison terms and forfeiture of assets have been used to discourage suppliers and manufacturers of drugs. Users are discouraged by facing stiffer and increased jail time. Possession of paraphernalia adds to the length of time spent in jail. Many states, including California, enacted three-strike laws in the 1980s, which mandated life imprisonment if an individual committed 3 felonies in their lifetime. Since 1980, prison populations have tripled. 55% of the inmates in federal prisons were convicted of drug offenses. If you count felonies committed to support drug habits, the percentage increases to 60 to 80%. Over half the inmates incarcerated admit to using drugs while they committed their offense. The percentage of teenagers is even higher. A great deal of money has been spent on supply reduction. Advocates estimate that it has resulted in a 10 to 15% supply reduction. The severe penalties have resulted in a delayed impulse to use. It has opened up treatment. It has kept people in treatment. Detractors of the policy complain of the minor impact on supply. These individuals support a more demand reduction approach. Demand reduction involves the three tiers of prevention. Primary, by promoting abstinence, help young people refuse drugs, delay the age of first use, encourage, if you can delay people's first use to after the age of 21, then the probability of them becoming an addict is reduced greatly. Encourage health and non-drug alternatives. The age of first use is the strongest predictor of drug use, drug or alcohol use. Individuals who experiment before age 12 have a 4 to 5 times likelihood of further drug use. Secondary prevention seeks to halt drug use once it has begun. This tier of prevention adds intervention to the primary strategies of education and skill building. The biggest problem with this program is denial by the user and their concealment of use, making them difficult to identify. Another problem with this tier of prevention is that there is a lag phase between the first drug use and physical and emotional problems. The user feels that the educational programs are overstated. The tertiary prevention seeks to provide treatment for the user to restore them to health. Compulsive drug use is addressed through group intervention, focusing on detoxification, abstinence, and recovery. Cue extinction therapy that desensitizes the user to people, places, and things that triggers use. Family therapy, group psychotherapy, or residential treatment is used. Instruction in relapse prevention and life management skills is used. Psychopharmacological strategies can be used. Promotion of healthy lifestyles, hopefully they accept those. And development of support and aftercare systems, and this is usually done through a 12-step program. Tertiary programs result in decreased drug use or abstinence in 40 to 50% of the cases. 74% reduction in crime. 1,400,000 people receive treatment nationwide every year. 7 million people are estimated to need treatment nationwide. Not all programs seek abstinence. Harm reduction programs recognize that recovery is difficult and many will relapse before they are able to live their lives drug-free. This technique focuses on minimizing the personal and social problems caused by drugs. 3 harm reduction programs. The needle exchange programs do reduce the spread of HIV and hepatitis C. Bleach distribution programs to reduce the spread of HIV and hepatitis. So you use a hypodermic needle in the case of using heroin, for example, and methamphetamine. You can inject any of the opiates. You can take the pills and crush them up, and then add water to them, and you can inject them. So what they're trying to do is they're trying to prevent HIV and hepatitis C specifically. So the needle exchange program has to do with the injectables, as does the bleach program. Legal drug substitution for illegal drugs, the replacement of heroin with methadone is a good example for the drug exchange program. Harm reduction programs have also proposed some controversial ideas. They accept the fact that people will experiment with drugs and they want to educate them to use drugs responsibly. This is what is done in overseas, in Europe especially. Decriminalizing or even legalizing illegal drugs. This is a real controversial. Treat addicts by reducing their usage to a manageable level rather than seek abstinence. This is also fairly controversial. Allow addicts to design their own intervention and treatment programs. And of course, that is controversial as well. Some of the most lucrative advertising on television is advertising for alcoholic beverages. Before 1996, hard liquor was not advertised on television, only beer. The idea from the temperance argument of the 19th century was that replacing hard liquor with beer would reduce drunkenness and the destruction of alcohol. However, more people die from cirrhosis of the liver caused by beer than cirrhosis caused by hard liquor. Damage done by legal drugs causes more damage to society than illegal drugs. Alcohol is legal, tobacco is legal, prescription drugs are legal, and now marijuana is legal in 30 of the 50 states. Advertising for these drugs brings new users into the fold every year. And of course, we haven't seen any advertisements for marijuana yet, but we do see advertisements for beer on television. They talk about prescription drugs all the time. It's illegal to advertise tobacco on television now. It wasn't for the longest time. I can remember all the tobacco commercials that were on television during the 50s and 60s and 70s before they made it illegal. Lucky Strike means fine tobacco. You know, they would have I Love Lucy was sponsored by Old Gold, I think, Old Gold cigarettes, and they would come out smoking cigarettes, Lucy and Ricky. Facts to remember about prevention: there are no quick fixes. Prevention will never be complete because there will always be new potential users to convince. Prevention campaigns become progressively more difficult in time because they have already reached the easy cells. No single approach has been shown to work consistently. Legalization of medical marijuana will make it more and more difficult to control all drugs. And of course, now that we have recreational marijuana being used in 30 out of 50 states, wow, it's going to get harder. When we see depictions of drug addicts in the media, they are often portrayed as weak, bad, stupid, crazy, immoral, poor, and disenfranchised. One third of the homeless have a drug or alcohol problem. This only represents about 5% of the addicts in the United States. The truth is that whites are the most likely to have either a drug or alcohol problem. African Americans are just as likely as whites to have a drug problem, but the least likely to have an alcohol problem. Hispanics are the least likely to have a drug problem. People in low-income areas are less likely to receive treatment and more likely to be incarcerated for their drug use. More affluent people are more likely to receive treatment and probation. 53% of the individuals in prison for drug crimes are African American. 26% of those in prison for drug crimes are white. Among the highest paid occupation in the United States, physicians, they are as likely to be addicted as the general population, though they are more likely to be addicted to prescription drugs. There was a television show, House, I think was what it's called, and that was the name of the doctor. He was addicted to prescription drugs, if I remember. Members of Mensa and gifted high school students have higher rates of addiction than any other group. Members of the clergy have high rates of alcoholism. While addiction rates fluctuate with attempts to curtail use, over the last 40 years, the age of addicts has declined with the age of first use. Between 1991 and 2005, the number of 8th through 10th graders who used marijuana increased 60%. Juvenile arrestees testing positive for drugs other than alcohol ranged from 48 to 65% in 2005. It is estimated that 18.6% of infants are exposed to alcohol in the womb. 4.5% of fetuses are exposed to cocaine. 17.4% of fetuses are exposed to tobacco. Fetal alcohol syndrome is the third most common birth defect and the leading cause of intellectual disability in the United States. My great niece, who was shooting up with heroin, used to take her picture, like to have her picture taken with her big belly and a cigarette hanging out of her fingers. So she was so cool. So she not only was cool, but she also was poisoning the child with heroin, and she was also poisoning the child with nicotine. Drug use during pregnancy can create nutritional and obstetrical complications, anemia, sexually transmitted diseases, diabetes, high blood pressure, neurological damage, weakened immune systems, poor nutrition, hepatitis C exposure, endocarditis, HIV, and AIDS exposure. When we say sexually transmitted diseases, in this case we're talking about, well, HIV and AIDS is usually a sexually transmitted, well, sometimes a sexually transmitted disease, but the other sexual transmitted diseases such as syphilis and gonorrhea are also a possibility, not to mention HPV, human papillomavirus. 80% of infants born with HIV in the United States were born to mothers who were IV drug users or the partners of men who are IV drug users. Worldwide, the figure is 90%. Unfortunately, the life expectancy of a child born with HIV is only 2 years. With AZT treatment for the pregnant mother, rates of HIV infection dropped from, that's not dropped, is it? I left a P out, from 25% to 8%. Magic Johnson had HIV, and he married a lady by the name of Cookie. That was her first name. And she was able to give birth to a child who was not infected with HIV because both she and Magic were on AZT treatment. Now, she never tested positive, but there is always a possibility. So she was on AZT treatment, and she gave birth to a child without HIV. Pregnant addicts often live chaotic lifestyles that don't afford time or the wherewithal to seek or accept prenatal care or medical intervention. When the addict is an adolescent, the individual is at greater risk and even less likely to seek treatment. Other problems are likely because of her physical, emotional, and behavioral immaturity. Besides the effect of the drug on the fetus, the mother's toxic environment often has deleterious effects on the fetus and the mother. Poor nutrition, bloodborne infections, domestic violence, and sexually transmitted diseases. Most psychoactive substances readily cross a placental barrier, meaning that the tiny infant is exposed to the same drugs at the same level as the mother. After birth, the drugs will be passed to the baby in the mother's breast milk. Because of the excessive organ and brain development, the first 12 weeks, first trimester, is the most critical period in the baby's life. Drugs used during the time period can change the baby both physically and mentally. However, since the brain continues to grow throughout gestation, neurological damage can be done at any juncture during gestation. If heroin or cocaine is used during the last trimester, they might cause premature birth. If the baby is born after the mother has used drugs on a regular basis, the neonatal period will be fraught with intoxication, withdrawal, and eventually developmental or learning delays. And all of these things have happened to my great-great-nephew. If the infant is given concentrated care after birth, they will manage to catch up with their non-drug exposed peers, potentially by toddlerhood. Alcohol has one of the most devastating effects on a fetus of all the drugs. The effects of alcohol have been studied more than any other psychoactive substance because of its prevalence and the general acceptability of the drug. And my great-great-nephew actually has caught up, except he has issues, rage issues. We're not talking about anger issues, we're talking about rage. The kid will go into a rage and he'll start throwing things. He's a pretty big kid, so it's when he starts throwing things, you got to get out of the way. Now at school, when he does this, they have a way of dealing with it. But when he has a rage at home, well, anyway, it's not pretty. When a mother drinks during pregnancy, the possible effects on the fetus are referred to as FASD, or fetal alcohol spectrum disorder. The most severe form of fetal alcohol spectrum disorder is fetal alcohol syndrome, or FAS. FAS is characterized by physical abnormalities, mental abnormalities, and behavioral abnormalities. These babies are born to mothers who drank heavily during their pregnancy. Growth of the FAS fetus occurs in the womb. They have reduced height, reduced weight, reduced head circumference, reduced brain growth, reduced brain size, facial deformities. They have shortened eyelids, thin upper lips, flattened midface, shallow groove in the upper lip. Heart problems, limb problems, delayed intellectual development, neurological abnormalities, behavioral problems, visual problems, hearing loss, balance, and gait problems. Part of FASD are less severe disorders, alcohol-related neurodevelopmental disorders, or ARND, alcohol-related birth defects, ARBD. Worldwide, FAS affects as many as 2.9 per 1,000 births. In the United States, the rate is 2 per 1,000 births. Among African Americans, the rate is 6 per 1,000 births. For Asians, Hispanics, and whites, they have rates between 1 to 2 per 1,000 births. American Indians have rates between 10 and 30 per 1,000 births. You might wonder, why is it so high for American Indians? Well, you know how much the Native Americans, American Indians in the Southwest are drinking. The group that drinks the most, that has the biggest problem, are the Northern Plains Indians, and their rates are higher, and that skews the results for the Southwestern American Indians as well. In one study of FAS adolescents and adults, it was discovered that all of them had been physically and sexually abused, 60% of the abuse occurring before adulthood. The individuals averaged 6 diagnosable mental illnesses. Select ones had 10 or more mental illnesses. Cocaine and amphetamines are used by 558,000 women in the United States every year, with most of them falling into the reproductively viable range. In the 1980s, when cocaine use was at its peak, it was estimated that 4.5% of all babies born in the United States were exposed to cocaine in the womb. In inner-city hospitals where cocaine use was more prevalent, the percentages ranged from 15 to 25%. I think I've told you that one of my jobs in the 1980s was working at a children's hospital in Omaha, and we used to get kids from all over Nebraska and all over western Iowa and southern South Dakota. And it was pretty bad. But the worst cases were the ones from right there in Omaha. It was the rich people were doing cocaine. That was the thing to do if you were. I mean, that was a cool thing to do, was using drugs, and it was ugly. It was really, really ugly. I would say the 4.5% of babies, it was probably closer to 10 to 15% of the babies that we had who had problems were due to cocaine. The effects of stimulants, increased heart rate, constricted blood vessels, affects not only the mother, but the unborn fetus. For the fetus, the constricted blood vessels results in restricted blood flow, restricted nutrients, and restricted oxygen, which reduces growth, reduces development. For habitual users, the effects can be more pronounced. In extreme cases, the increased blood pressure may cause the placenta to separate from the uterine wall, resulting in spontaneous abortion. Excessive use of stimulants can raise the fetus's blood pressure, causing a stroke. Using in the third trimester can result in extreme activity in the fetus, causing uterine contractions and premature labor. Withdrawal from for the fetus involves several weeks of extreme agitation, increased respiration, hyperactivity, and possible seizures. Effects last into the child's second year with lifelong disability rates of 33%. And I'm assuming that's what's going to happen with my great nephew. He's 8 years old now, I think, and he's got some pretty interesting problems. Since opioid use tends to be more continuous than the binge use of stimulants, the effects are greater. Problems include severe infections from IV drug use for the mother, fetal growth retardation, miscarriage, stillbirth, separation of the placenta from the uterus. Babies are born to heroin addicts are often premature, smaller, and weaker. These infants have abnormal sleep patterns that leads to a 600% increase in SIDS deaths. 60 to 80% of babies born to opioid-addicted mothers go through withdrawals 2 to 3 days after they are born. Hyperactivity, which causes irritability, incessant high-pitched crying. Hyperactivity, incessant high-pitched crying, increased muscle tone, irregular sleep patterns, increased respiration, poor suckling, failure to thrive, irritability, sweating, tremors, diarrhea, sneezing, vomiting, and death are some of the problems. When we had kids with this problem, they would have to rotate the nurses in and out because of the incessant high-pitched crying. It was like a cat screaming, and it was continuous. Marijuana is used by 5 to 17% of pregnant women during their pregnancy. A longitudinal study of marijuana-exposed fetuses in Canada showed that poor short-term memory and verbal reasoning at age 3, continued poor memory through childhood, lowered verbal performance through childhood, impulsive hyperactive behavior, conduct problems, distractibility, poor executive function. They did a study in New Zealand where they discovered that children who had been exposed to, or these are children that smoked pot before the age of 12, lost 10 to 20 points off their IQ score. Not a real good idea. Marijuana is not the best idea that we've ever had, for sure. Problems with marijuana is the same as the problem with any other drug smoked. Decreased oxygen, irritated alveoli and bronchi in the lungs, decreased weight, withdrawals, abnormal responses to visual stimuli, increased tremulousness, easily startled, high-pitched cry. Fetal effects, category A, vitamins and other drugs than A, or vitamin A. No fetal risks. It's okay to take vitamins. This is one of the reasons why they give you the prenatal vitamins. Category B, acetaminophen and ibuprofen. There are no fetal risks to category B drugs. Category C, most medications. No fetal risks with most pharmaceuticals. Category D, anti-seizure and benzodiazepine and tetracycline. We know that anti-seizure medicine is, of course, for people with epilepsy, but it's also given to people that are suffering from bipolar disorder. Benzodiazepines are for anxiety, and tetracycline is an antibiotic that is used for acne, as interesting as that is. So they are category Ds. In this case, fetal risk, but the risks are considered appropriate to the need of the mother. So if she has epilepsy, she can take her anti-seizure medicine. If she has a problem that only tetracycline will help, she can take the tetracycline. If she has anxieties, then she can continue her benzodiazepines. Category X are teratogenic, Accutane, which is a strong form of tetracycline, and vitamin A. Fetal risks are too great for the benefits, and so don't do it. Any medication prescribed for a pregnant woman should be closely monitored. Use of NSAIDs, nonsteroidal anti-inflammatory drugs, can elevate the pregnant mother's blood pressure. Benzodiazepines can accumulate in the fetus's blood, even at safe levels for the mother. Because of the fetus's smaller system, it will take longer for the infant to clear the drugs from his system, and the baby may be born addicted. Because of the slowness in clearing the infant's system, the baby will be born with withdrawals that may persist for weeks. At the turn of the 20th century, women rarely smoked. In 1920, only 5% of pregnant women smoked. Pregnant women smoking peaked in 1997 at 28.2%. In 2005, only 22.5% of pregnant women smoked during their pregnancy. 17% of the women smoked cigarettes. 8.82% smoked right up to the time they gave birth. The highest rates were among African Americans at 20.12%. The second highest rate was among whites at 14.2%. The thing that you need to know about tobacco, the tobacco lobby was very strong in the United States. They had doctors that were suggesting that if a woman was suffering from morning sickness, that they needed to smoke to take away the nausea. Did it work? Well, who knows? This is back in the 50s and 60s. So, cigarettes are especially dangerous because of the nicotine and carbon monoxide found in the smoke, along with 2,000 other compounds. Both carbon monoxide and nicotine cross the placental barrier and reduce fetal oxygen supplies. Women who smoke or come in contact with secondhand smoke are in greater risk of premature delivery. Heavy smoking mothers are twice as likely to miscarry or have spontaneous abortions. Babies born to heavy smokers average a birth weight of 7 ounces less, with a smaller head circumference and about an inch shorter. With heavy smokers, there is a higher incidence of cleft palate, congenital heart defects, minor nerve and brain defects, higher incidence of SIDS, sudden infant death syndrome, weaker sucking reflex, depressed immune system, more respiratory infections. Caffeine is a common drug taken in by pregnant women in tea, coffee, and soda pop. In one study, 75% of babies born had caffeine in their system at birth. Infants tend to have a lower tolerance for caffeine than adults. Caffeine seems to have no long-lasting effects on the child, though physicians warn pregnant women away from its use during pregnancy. And my daughter, who is a really good girl, decided that when she got pregnant, she would not use caffeine. Really tough for her because she was drinking a lot of Diet Pepsi at the time, and so after she got pregnant, she didn't drink any tea, coffee, or soda pop, and she was a really good girl. And now the kid is perfect. My grandson is perfect. Prevention of damage, she was 42 at the time when she got pregnant for the first time, and she decided that this is her only shot, so she needed to do the best job she possibly could. And of course, we both were aware of what was going on. She's a biologist, and of course I teach this class and other classes, so I was very well aware of how dangerous the pregnancy was. So we both monitored it through her pregnancy, and she was able to carry the baby to full term. But unfortunately, her hips weren't wide enough, and she had to have a cesarean section. She tried to have it naturally, natural childbirth, but it was just too small. He was too big. He had a big melon. Prevention of damage should start as soon as the woman discovers that she is pregnant. Physicians will ask the woman the 4 Ps. Parents, did either of the woman's parents have a problem with drugs or alcohol? Partner, does the woman's partner have a problem with alcohol or drugs? Past, has the woman ever drunk beer, wine, or liquor? Pregnancy, in the month before the woman knew that she was pregnant, did she smoke cigarettes, take drugs, or drink beer, wine, or liquor? If necessary, the woman can be treated for her dependence. The most frequently abused drugs, 46.5% among high school seniors. But that was among 46.5% of high school seniors. Tobacco, 21.6%. Marijuana, 18.3%. Smokeless tobacco, 6.1%. Painkillers, 3.8%. Amphetamines, 3.7%. Tranquilizers, 2.7%. Cocaine, 2.5%. Inhalants, 1.5%. Hallucinogens, 1.5%. MDMA, 1.3%. Steroids, 1.1%. Heroin, 0.4%. Any illicit drugs, 22.1%. In the last 30 years, tobacco and alcohol use has actually declined, while marijuana use has primarily stayed the same. The school environment has the greatest influence on drug and alcohol use. If the individual can reach the age of 21 without smoking and drinking, they probably never will start. Of the people who experiment with alcohol or tobacco, more susceptible to peer pressure maybe, 85.7% are still smoking in the 12th grade. If they have been drunk sometime in high school, 83.3% are still getting drunk. If they have ever tried marijuana, 76.4% are still toking, which is an old word for smoking pot. Adolescents who use marijuana weekly are 6 times likelier to cut class or skip school. One of the great oxymorons of adolescence is that while they think of their own thoughts as beyond question and their lives as invulnerable, they commit some of the most ill-advised acts that can sometimes lead to death. Intoxication in driving, intoxication in having sex. 70% of teen suicides involve alcohol. 50% of the date rapes include alcohol. 40% of the drownings involve alcohol. Alcohol and drug use among adolescents has a great deal to do with crime. More than half of the juvenile males arrested test positive for one or more illegal drugs. Marijuana is the most frequently found drug among these individuals, despite the fact that people like to say that it mellows you out, dude. Well, maybe it does, but these people are committing crimes while they're mellowed out, dude. One of the major reasons people use psychoactive substances is to delay taking care of their problems. When this happens with an adolescent, they may not learn to deal with life's conflicts until they are deep into adulthood. They have prolonged the maturation process. Factors that lead to an adolescent to use psychoactive substances: being subject to physical, sexual, or emotional abuse, being mentally or emotionally disturbed, lacking self-esteem, peer group encouragement to use drugs, inconsistent discipline where drug use is tolerated, dropping out of school, getting caught in the juvenile justice system, getting pregnant, living in poverty, lacking alternative activities, being in a school that does not control drug problems. Factors that help children avoid drugs: strong sense of family participation and involvement, family position on drugs, alcohol, and sex that the child can adopt as their own, strong spiritual sense and community involvement, attachment to a clean and sober adult role model. There are programs that have been developed to help school-age children, K through 12, stay away from drugs and alcohol. You may have heard of the DARE program, Drug Abuse Resistant Education, 16 to 17 week sessions conducted by uniformed police to 5th and 6th graders. Dare to Be You is another program. Family Matter is another program. Lions Quest Skills for Adolescents, and this is a program that I worked on when I was living in California. The RAND Corporation was doing surveys using Lions Quest. We were experimenting, not experimenting, we were giving surveys to all the middle school students in the Los Angeles area. And that's one of the jobs that I did back in the 90s. Is that right? Was that 90s? I think so. Anyway, Lions Quest. Multi-systemic therapy, MST, New Beginnings program. Project Towards No Drug Abuse, PTND, okay. Seeking Safety and Life Skills Training, which increases social skills to help resist peer pressure. All the programs to help prevent drug abuse are similar. They all involve a coordinated effort among family members, teachers, and other school officials. These school-based programs tend to teach life skills, resistance education, and normative education. Normative education aims at correcting erroneous beliefs about the prevalence and the acceptability of alcohol and drug use among an individual's peers. Family-focused primary prevention is a necessary adjunct to any school-based program. Experimentation, social use, habituation, and abuse usually begins in junior high school. That's the 6th, 7th, and 8th grades. Because of this proclivity, primary prevention needs to continue while secondary prevention is put in place to deal with those who didn't get the message. School personnel and families should be trained to recognize drug use and how to deal with the consequences. For those students who begin abusing drugs on a regular basis, treatment must be sought to reduce the probability of a lifetime of abuse. Such a program is a positive behavioral interventions and supports, PBIS, adjustments to the environment to reduce the problem, building general competencies and teaching replacement skills, implementing consequences to promote positive behaviors and deter problems, crisis management or relapse plan. 1 in 4 children in the United States is exposed to alcohol abuse or dependence in their family. These children will be affected by alcohol even when they don't use. These children may play different roles in their family. A hero or model child tries to bring pride to the family. The problem child demands attention and is the most likely to use psychoactive substances. The lost child, they tend to be shy and they sidestep problems by avoiding family and social activities. The mascot or family clown tries to ease tension in a dysfunctional family by being funny or cute. They have a hard time growing up. Now, you can have all of these children in your family. You can have the hero. You can have a hero in your family, a problem child in your family, a lost child, and a family clown. Uh, and a lot of families have each of these. Many alcoholic beverage companies target their advertising toward college freshmen, as establishing brand loyalty may generate as much as $20,000 to $50,000 revenue over the individual's lifetime. This is really kind of funny because I had a college reunion a couple of years ago. That was our 50th college reunion. And some of these guys were still drinking the same beer they were drinking in college. It wasn't because they came to campus where they had been drinking this stuff. They've been drinking this stuff all their lives. So they're right. If you can create a brand loyalty to a select, Rolling Rock was real popular in one of the fraternities. I think they were Phi Delts. There were Rolling Rock guys. Anyway, the Rolling Rock, they were still drinking Rolling Rock. The guys from the Phi Delta Theta House that were still alive, as you can imagine, 50 years after graduating from college, how many of them were still alive in their 70s? And the answer was not that many. 49% of full-time college students binge drink and or abuse prescription and legal drugs. This is 2.5 times the amount of abuse found in the general population. One of the things you have to remember, we're talking about drinking alcohol, but remember in the 60s, only 2% of people had used illicit drugs. So what was happening when I started school, started college in 1967, was that beer was about it. There were people that were drinking hard liquor of just about everybody. And Indiana's a relatively dry state, and we were going to college across on the other side of the state, away from Ohio. So it was hard to get alcohol at the campuses, on campus. So people were drinking. If they drank anything, they usually drank beer. So what's my point? My point is that they weren't using other drugs, but they did drink a lot of beer. A lot of the fraternities did. I was an independent, so I didn't have to worry about that kind of stuff. I ran into it from time to time because there were people that did drink in the dormitory, but not as it wasn't as bad as if I had been a member of a fraternity. The statistics on college students has varying degrees of positive and negative. Daily smoke. You're going to find out that I'm probably the most boring individual that has ever existed. I'm just not cool at all. And I'm sorry, that's just the way I am. If you need a cool instructor, you're going to have to go to somebody else because I ain't it. The statistics on college students has varying degrees of positive and negative. Daily smoking dropped from 15% in 1993 to 12% in 2005. Fraternity and sorority members are more likely to drink than non-members, 88% versus 67%. Binge drinking, 64% versus 37%. This is the fraternity is the first large number. Driving drunk, 33% versus 21%. Using marijuana, 21% versus 16%. And smoking, 26% versus 21%. One of the things you need to remember about my era, 1967, there wasn't hardly any marijuana around until the anti-war movement started, and then it started coming onto our campus. But it was relatively rare in the 60s, and then became more prevalent in the 70s. Only 6% of addicted college students seek help. 78% of college students who use illicit drugs have sex compared to 44% of those who never use drugs. And of course, we were an all-male college and still are. One of only two left in the United States. Psychoactive substances do have a heavy impact on our college campuses. 1,717 deaths in 2007 from alcohol-related injuries, 97,000 victims of alcohol-related rape or sexual assault, 696 assaults by another student who has been binge drinking. In 2002, the federal government legislated to deny college students federal aid if they had a drug conviction on their record. Of the 10,437,000 who applied, 41,000 were denied aid, while an equal number were waived who had completed a drug treatment program. Even the non-drinkers are affected by the drinkers. In a study of a campus where over 50% of the campus were binge drinkers, 87% of the non-drinking other students reported being victims of assault, being victims of unwanted sexual advances, having sleep interrupted, having study interrupted, suffering property damage, having to care for a drunken student, having to clean up after a drunken student, having impaired quality of life because of the drinking. We had one guy that was really bad. Anytime he drank gin, he became violent. So neither of these two, we were an all-male college. Having sleep interrupted, certainly. Having study interrupted, certainly. Suffering property damage. He tore a railing off the wall, a stair railing, and he rammed it through a window. Having to care for a drunken student, certainly. Having to clean up after a drunken student, certainly. Having impaired quality of life because of the drinking. This especially was true when I was in the service, and I'd be the dorm monitor. That's usually what happened during the weekends. Somebody was in charge, and it was your responsibility to keep things clean. Oh, God, what a mess. Military personnel are the worst. Drinking and drug experimentation are seen by some as a rite of passage for college students. However, and I will have to admit, when I went to college, I went to a mixer at a fraternity, and I drank beer at age 17. I drank a beer, or at least I tasted a beer. It was nasty, and I've never I have had beer since then, but it was pretty bad, and it just tasted so bad. I couldn't imagine wanting to have any more. However, one approach to the control of college drinking is a normative approach where the myths of rampant drinking are debunked. For example, 68% of college students thought that their peers thought frequent intoxication was acceptable, while only 14% actually did. Within 18 months, within disseminating normative information, one college campus found 16% reduction of drinking to get drunk, 21% reduction in frequent heavy drinking, 31% reduction in missed classes, 36% reduction in property damage, 40% reduction in unprotected sex. Means of controlling alcohol use, regulate campus drinking, 25% of campuses ban beer, 32% prohibit liquor on campus, 98% prohibit kegs in dorms. provide alcohol. One of the reasons that fraternities and sororities get away with this stuff is because a lot of times they're not on campus, they're off campus. And for that reason, the college can't really control that behavior. But they can suspend the fraternity or sorority from campus activities. That happened on our campus. We had an individual that died. He jumped off the roof when he was drunk, and they suspended the fraternity for 5 years. They are back now, but they're limiting their drinking, I hope. Provide alcohol, tobacco, and drug-free dorms, wellness halls. 2/3 of campuses offer such dorms. Prohibit alcohol at campus events and fraternity sorority parties. Announce and enforce campus alcohol and drug policies. Work with the local community to make sure that alcohol is not served to minors. Strengthen academic requirements. Means of controlling alcohol use on college campuses. Schedule more classes on Friday. Keep the library and recreational facilities open longer. Prevent alcohol promotions on campus. Notify parents when students run afoul of the drug and alcohol regulations. Provide server training for bartenders at college-sponsored functions. Ban alcohol beverage advertising in college newspapers. 50% of campuses ban such advertising. Integrate substance abuse education into the curriculum. Maintain a substance abuse officer to oversee on-campus use and abuse. Join a higher education prevention consortia. 90 such consortia do exist. Create programs to work with the neighborhood and community. Initiate early detection, intervention, enforcement, and referral. Studies show that a good drug education program will actually increase the level of experimentation but decrease abuse. Bad education will actually increase abuse. Studies show that as most college students mature, their alcohol and drug use becomes more sensible. People take psychoactive substances either to enhance some aspect of their sexual sensation or not realizing that it will interfere with their sexual sensations. Select psychoactive substances can replace normal sexual emotions, meaning that the emotions will seem to be there when they are not. These emotions are intimacy, comfort, love for one's children, and release from anxiety. Love, sex, and drugs, a glass or two of wine to get in the mood, a cigarette after sex, a popper to intensify an erection or orgasm, amphetamines to delay ejaculation, marijuana to enhance the newness of the situation, ecstasy to increase empathy. Drugs are desirable when the individual feels a physical, social, or emotional deficit. This happens with aging or shyness or lack of confidence, diminished desire, diminished abilities. Unfortunately, the same drugs when used long-term may create the reverse effect: lack of sexual interest, physical depression, inability to achieve an erection, inability to achieve an orgasm. Drugs may trigger sexual aggression, sexual harassment, rape, child molestation, high-risk sexual behavior. The three main effects of a psychoactive drug on sexual behavior are desire, excitation, and orgasm. They do this by releasing hormones, by affecting blood flow, by affecting blood pressure, by affecting nerve sensitivity, by affecting muscle tension. Some examples of psychoactive interference with normal sexual activity: heroin desensitizes penile and vaginal nerve endings, making it less likely to impossible that you will have a good time. Alcohol diminishes spinal reflexes, decreasing sensitivity and erectile ability. Steroids increase testosterone, making the user more sexually aggressive. Cocaine and amphetamines release dopamine, which mirrors the release of dopamine during orgasm. Many drugs affect the hypothalamus, which can trigger unwanted hormonal changes. Chronic drug users combine sex and drugs to lower their inhibitions, to try to make themselves perform better, to increase their fantasies, to shield themselves from their sexuality, to remove themselves from emotional involvement. Alcohol's effects on sexual function are directly related to the blood alcohol levels. Women may use alcohol to lower inhibitions, to increase sexual pleasure, and raise self-esteem and feelings of inadequacy. And reduce feelings of inadequacy. However, with the increase of alcohol, there is actually less of a chance of orgasm. Women are more likely to drink to hide sexual dysfunction than men are. Engaging in sex seems to be something to do while drunk. For men, enough alcohol can actually prevent them from being able to have an erection, as it diminishes spinal reflexes, decreasing sensitivity and erectile ability. Alcohol also lowers testosterone level while increasing the female hormone estradiol. Chronic male drinkers will have a greatly decreased testosterone and greatly increased estradiol, creating abnormalities in sex steroid metabolism. Men like alcohol because it anesthetizes the area of the brain that causes fight, flight, and fear, making them more aggressive. However, it does lower testosterone, making men more likely to act asexual. In one study of heavy drinkers, 60% reported being impotent. Amphetamines and cocaine have always had the reputation of being sexual enhancers, but this is especially true in the gay community because it increases confidence, it prolongs erections, it increases endurance, and it intensifies orgasms. This is especially true of methamphetamine, which lasts longer in the individual's system. Amphetamines and cocaine can greatly intensify the pleasurable feelings that an individual gets from sex. Unfortunately, with continued use in sexual situations, the intensity lessens. As dysfunction begins, the individual will seek to use more and more of the drug to achieve normal sexual functioning. The drug will also intensify pre-existing sexual proclivities. If this is something as harmless as sexual inhibition, it will make the individual more confident. If the proclivity is pedophilia or rape, the drug can intensify these behaviors as well. While cocaine may work wonders for men, when first used with prolonged use, the effects may be unintended. It may delay ejaculation, decrease in sexual desire, difficulty achieving ejaculation. In women, cocaine may disrupt the menstrual cycle, cause difficulty in achieving orgasm, and decrease desire. Smoking after sex has become a cliche for having had sex. In truth, long-term tobacco use is associated with a lower testosterone and erectile dysfunction. In women, it causes reduced fertility. The opioids are depressants, and so may act to lower an individual's inhibitions when first used in concert with sex. However, with prolonged use, long-term users report impaired performance and a decrease in sexual drive. In one study, the degree of impotence among males was 39%, jumping to 53% when the individuals were actually using the drug. Some of the sedative hypnotics have been touted as sexual enhancers: benzodiazepines, barbiturates, and quaaludes. The reality is that the individual has lowered inhibitions, which makes it more likely that they will be willing to perform sexually. With prolonged use, the individual begins to suffer from sexual dysfunction and apathy towards sexual stimulation. Select sedative hypnotics have been used as date rape drugs. Rohypnol causes amnesia and lowered inhibitions that makes an individual less likely to resist a sexual assault. GHB lowers inhibitions and makes sex more pleasurable. Too much can lead to sleep or even coma. The drug also has amnestic effects. In other words, they don't remember what happened to them. Marijuana's effects have much to do with the attitude of the individual when smoking, much like LSD. In a pleasant social situation, like at a party or on a date, the drug will make people less inhibited and more relaxed, making it more likely that they will do things that they wouldn't normally do. Research looking at marijuana in a controlled setting found that the drug inhibited orgasm, but not desire. The biggest problem with chronic marijuana use is that the user does not learn to have sexual relations without being stoned. MDMA and MDA give their user a warm feeling toward others and induces heightened sensual awareness. However, the heightened sensual awareness does not enhance the ability to have an erection. As well, orgasms are more difficult to achieve. Sexual excitement is unlikely when high on the drugs. If this response is going to occur, it is usually as the person is coming off the drug. Neither PCP or LSD are considered sensual drugs. As an anesthetic, PCP has been used to deaden the pain in select sexual practices in both the gay and the heterosexual communities. LSD, and as a matter of fact, no psychedelics, are known as sexual enhancers. Nitrites are used in both the gay and straight community as a vasodilator and a muscle relaxer. Users claim that nitrites prolong and enhance orgasmic sensations if used just prior to the orgasm. Like Viagra and other erectile dysfunction medications, nitrites act as vasodilators, promoting penile erection. Nitrites also relax the anal sphincter muscles, supporting anal intercourse. Psychotropic medications often will interfere with sexual functioning. Tricyclic antidepressants have been linked to decreased desire, problems with erection, and delayed orgasm. Selective serotonin reuptake inhibitors also cause delayed or inhibited orgasm and impaired erection abilities. Antipsychotics inhibit erectile function and ejaculation as well as desire. With heavy doses of lithium, desire decreases and individuals report having difficulty maintaining erections. Aphrodisiacs actually may not exist, though some drugs will enhance sexual situations. The erectile dysfunction medications, Viagra, Cialis, and Levitra, allow increased blood flow to the penis, but do nothing for sexual desire. Spanish fly irritates the bladder and urethra, but does not actually increase desire. Human pheromones increase sexual desire and sexual stimulation, but only select pheromones work on select people. Yohimbine can enhance blood pressure and heart rate, increasing penile blood flow, but not desire. Drugs are often present in cases of sexual assault. 51% of victims reported using drugs or alcohol before the assault. 44% of the assailants used drugs or alcohol before the assault. Irrational or inappropriate desires may occur after alcohol lowers inhibitions and muddles rational thought. Stimulants make the user feel more confident and aggressive, making it more likely that a date will be assaulted. Sedatives lower inhibitions, making women more susceptible to assault. Marijuana makes users more suggestible to sexual activity. PCP and heroin make users less sensitive to pain, making it more likely that they will damage their partners during sex. Drug use peaked in the 1980s. Positive drug rates at work were 13.6% in 1988. By 2006, with actually more drug testing, the rate had dipped to 3.8%. The lower drug use levels at work may be due as much to drug users avoiding companies that drug test as drug usage at work declining. Estimates are that 8.2% of all workers use illegal drugs. 8.4% of full-time workers are heavy alcohol users. Contrary to the image of the addicts skulking around alleys to support their drug habit, 74.8% of addicts over 18 are employed as full-time or part-time employees. 80% of the binge drinkers are employed. 62% of the people diagnosed with substance abuse disorder were employed. Unfortunately, substance abusing employees do not make good employees. They are late 3 to 14 times more often. They are absent 5 to 7 times more often. They make more mistakes than other employees. They tend to have a lower output. They are more likely to appear in a greater number of grievance hearings. They are 3 to 4 times more likely to have an accident on the job. They use 3 times more sick leave. They file for workers' compensation 5 times more frequently. They overutilize health insurance along with their families. They cause premiums to increase for medical insurance. They endanger the health and well-being of coworkers. What is this? What did I say? Oh, sick leave. I haven't had a day of sick leave since I was in the Air Force. The most common drug found in employee samples, marijuana 48.8%, cocaine 16.4%, amphetamines 9.3%, opiates 6.7%, benzodiazepines 5.4%. 26% of people tested for cause tested positive. The area of the country that was the most likely to have positive drug tests was in the rural South. Employee Assistance Programs, or EAPs, are programs established to help employees become better employees by providing treatment and counseling when needed. 45% of all employees in the United States are covered by EAPs. 70% of all employees working for organizations with more than 500 employees are covered by EAPs. EAPs do work. Northrop saw a 43% increase in production from the first 100 employees they sent to an alcohol treatment program. Employees of the Philadelphia Police Department who went through treatment reduced their sick days by 38% and their injury days by 62%. Providing EAPs for employees at the Oldsmobile plant in Lansing reduced their lost work hours by 49%, healthcare claims by 29%, sick leaves by 56%, grievances by 78%, disciplinary problems by 63%, and accidents by 82%. Of course, Oldsmobiles aren't made anymore, and the Lansing plant is closed. They haven't made Oldsmobiles for what, 15 years? There are several types of EAPs based on financial needs. Internal in-house programs are found in large companies who can afford the expense. Fixed fee contracts, the company contracts at a set fee for any programs needed. Fee for service contracts, the company contracts with an outside EAP on an as-needed basis. Consortia, smaller employers get together to contract with an outside EAP service. Peer-based programs, peers and coworkers provide the needed services. The military has been at the forefront of drug testing since the war in Vietnam. And this is one of the jobs that I had when I was in the service. Of course, I was in the service during the Vietnam War, and drug testing was one of the things that I did. In the late 1970s, drug testing in Europe peaked at 1 in 3 soldiers testing positive for illicit drugs. And I was actually in Europe at that time, but I wasn't one. I was testing the soldiers. I wasn't one of them that tested positive. In 1980, 27.6% of soldiers in the military tested positive for illicit drugs. And I was the one collecting the drug urines. By 1998, the level of illicit drug use in the military dropped to 2.7%. Why is that? Because we kicked the guys out who were testing positive. By 2005, the level had been cut by more than 100% to 1.11%, and they're still being tested at the same level as they were when we were getting figures like 27.6%. But we can test more drugs now than we were testing back then. Intense drug testing can be credited for this success. The military has maintained a reputation for heavy drinking since its inception. It wasn't until after Vietnam and the drug control movement that the military began concentrating on curbing instead of promoting alcohol use. In 1980, the level of heavy drinking in the military was around 20.8%. By 1998, the level had been cut to 15.4%. At present, the level has actually increased to 17.1%, higher than the general public at 12%. Now, you may ask yourself, why is this? One of the reasons that I see is that the military is, we've been fighting those wars in Iraq and Afghanistan for one thing, but the other thing is high testosterone levels. Military personnel tend to have high testosterone levels, and this makes them do extreme things. One of the extreme things they do is use drugs and alcohol. The highest rate of alcohol abuse in the military is in the Marine Corps branch. The lowest level of alcohol abuse is in the Air Force, with the other 3 branches of the military, the Army, the Navy, and the Coast Guard, somewhere in the middle. The Air Force was the first branch of the service to crack down on drug and alcohol abuse, and they have been at the forefront of drug and alcohol abuse among the services. The first military EAP was the Air Force's Alcohol and Drug Abuse Prevention and Treatment Program, the ADAPT. The Army soon followed with the Army Substance Abuse Program, the ASAP, and the Navy's Navy Alcohol and Drug Abuse Prevention Program, the NADAP. The military's programs have been so successful because the military has almost absolute power over all military personnel. They can conduct urinalysis testing whenever or wherever they choose. One of the things that we were doing in Vietnam, we were testing people before they could come home. So one of the things they had to do was, if they were using drugs, if they wanted to come home and not stay in country for an extended length of time, they needed to test negative for drugs. If a military member refuses to comply to either drug testing or drug rehabilitation, the military can charge them with disobeying a direct order and can discharge them from the service. And this is one of the ways that they reduce the amount of drug and alcohol usage in the military. You cannot refuse to take a drug urine test. You have to collect your urine specimen, and you have to be observed while you're doing it. And that was the job that I did. With the influx of reservists and National Guard members into active duty with the hostilities in Afghanistan and Iraq, the Department of Defense instituted the following drug policies: 100% of random testing of all active duty personnel, conduct random drug testing on all military personnel within 72 hours of entering active service. And this is the first thing that we did when we came into the service. First thing we did was collect a drug urine specimen. Separate positive testing personnel from the military, zero tolerance. Test the mandatory test panel to include new drugs. Maintain 100% mandatory testing for Department of Defense civilian personnel. There is a reason why drug testing has shown a 66% drop in positives from 1988 to 2004. Self-reported positives have increased 30%. Drug users will avoid applying for jobs at businesses that require a drug test. There are ways to beat the drug test, though most of them depend on a non-observant specimen collector, which I was not. Reasons for drug testing include pre-employment testing, for-cause testing, random testing, post-accidental testing, periodic testing, rehabilitation testing of criminals on probation, testing for compliance of addicts in treatment, testing by medical examiners to determine cause of death. 12 states allow for testing of welfare recipients. The most widespread testing is in the military, federal government employees, pre-employment drug testing, in public safety positions such as transportation and drug treatment facilities. Drug testing can be conducted on any substance from the body: urine, blood, hair, saliva, sweat, or tissue if necessary. That's usually with a cadaver. Urine is the most widely used means of testing. Standard drug testing is tests for amphetamines, cannabinoids, cocaine, opioids, phencyclidine, PCP, and alcohol. When I was testing, we could test for these, for barbiturates and benzodiazepines, methadone, propoxyphene, and methaqualone. We were testing for amphetamines, cocaine, opioids, and barbiturates. That's what we were testing for. We couldn't test for alcohol. Yes, we could, but it had to be a specific test. And we couldn't test for cannabinoids. This was in the 70s and into the 80s. Drugs that are normally not tested for but can be added if suspected: LSD, fentanyl, psilocybin, MDMA, MDA, and the designer drugs. Methods of testing include thin layer chromatography, or TLC. This method tests for a wide variety of chemicals and is very sensitive to minute amounts of any chemical. The problem is that it can't differentiate between chemicals with similar structures. For example, ephedrine and amphetamines look alike. Enzyme multiplied immunoassay techniques, EMIT, and radioimmunoassay, RIA, and enzyme immunoassay, EIAs. We use TLCs and RIAs when I was doing it. That was a million years ago. EMIT tests use antibodies to seek out specific drugs. It is very sensitive and rapid, but it cannot determine concentration and produces several false positives. Poppy seeds will test as heroin. Ibuprofen will test as marijuana. Vicks vapor inhaler will test as crank. Gas chromatography, mass spectrophotometry combined in gas liquid chromatography. This system is the most sensitive, accurate, and reliable method of drug testing. This system is so accurate because the technique actually breaks each chemical into fragments and then reads the fragments. This method eliminates false positives and false negatives because it not only identifies the chemical structure of the drug, but it cross-references it with the metabolites that it produces. This test is very expensive and requires highly trained operators. And this is how we would do TLCs. If that turned positive, we did an RIA. If they were still positive, then we did gas chromatography to determine what and how much they had in their system. Hair analysis can be done as most chemicals taken into the body are represented in the keratin of the hair follicle. Hair analysis tells the tester that what drugs have been used while that specific hair follicle has been alive. Radioimmunoassay tests are run on the hair follicle. Confirmation is done with gas chromatography and mass spectrophotometry. Mass spectrometry. Drugs can be detected on saliva, sweat, and on the breath. These tests are easier to obtain as they are less invasive, but they also only serve as screening tests and are prone to contamination. The alcohol breathalyzer is a good example of a breath test. Follow-up tests should always be done to confirm any results. And what we did in the military, and actually when I was working in the emergency room in Nebraska, if we had a positive test, or if they refused to have if they couldn't collect a urine specimen, we would draw their blood and confirm what we had. If they had a positive breathalyzer, then they'd come in for a blood test, and we would tell them exactly how much they had in their system. There are many factors that influence the length of time a drug will remain detectable in a person's system. It all depends on the drug, as we have talked throughout this class. Absorption rate, metabolism, rate of distribution in the body, excretion rate, the method employed for testing. All of these things will influence the level of drug that you get. Detection range of psychoactive drugs. Alcohol will stay in your system or will be detectable for 3 to 5 days. Amphetamines, 2 to 4 days. Methamphetamines, 2 to 4 days. Barbiturates, short-acting barbiturates, 24 hours. Intermediate barbiturates, 40 to 80 hours. And diazepam, which is Valium, 7 to 30 days. Cocaine or crack will stay in your system for 6 to 8 hours. Meth will stay in your system for 2 to 3 days. Marijuana, single use, 1 to 3 days. 4 joints a week, 4 to 7 days. Daily use, 10 to 15 days. Chronic heavy use, 1 to 2 months. Nicotine will be detectable for 12 hours. Detection rate, opioids, buprenorphine, 48 to 56 hours. The buprenorphine conjugates, 5 to 7 days. Codeine, 1 to 2 days. Heroin, morphine is measured 2 to 4 days. Dilaudid, 2 to 4 days. Methadone, 2 to 3 days. Maintenance methadone, 7 to 9 days. Morphine, 2 to 4 days. Oxycodone, 2 to 4 days. Propoxyphene or Darvon, 6 to 48 hours. PCP, if you use it casually, 2 to 8 days. Chronic heavy use of PCP, several months. LSD, 2 to 4 days, and ecstasy, 30 to 48 hours. Drug testing does seem to be reliably accurate, but it is not infallible. False positives can happen when Dextromethorphan has been misidentified as opiates. Some herbal teas have been known to test cocaine positive. Poppy seeds from baked goods have been misidentified as opiates. Errors have also been found after testing personnel mishandled specimens. And this is usually what happens. People will say, well, I didn't take any drugs. It must have been a lab error. Lab errors do happen. I've never made a lab error, but there are people that didn't care as much as I did. However, the most common laboratory errors are false negatives. Specimens can be manipulated by the testee to create a negative test when the testee is actually positive. Clean urine can be introduced into the specimen by concealed containers. Urine injection into the bladder, clean urine into the bladder, and catheterization. Substances that have been introduced into the urine to mask the drugs present with more than questionable results include aspirin, golden seal tea, niacin, zinc sulfate, bleach, clear, water, ammonia, Drano, hydrogen peroxide, lemon juice, liquid soap, vinegar, and Visine. These are all substances that a drug specimen collector will not be watching well enough. And of course, and they'll try it. They'll do just about anything. I've seen lots of stuff, but I've caught them all that I'm aware of anyway. Of the people over 65, 83% take at least one prescription drug per day. 30% take 8 drugs or more a day. 17% of people over 60 in the United States abuse alcohol and legal drugs. Unfortunately, our society doesn't pursue elder drug abuse and alcoholism as fervently as they do these problems in younger individuals. Only 37% of elderly alcoholics are identified as compared to 60% of younger abusers. Drugs do not work the same in the system of an elderly individual as they do with someone who is younger. Enzymes in the elderly tend to be less active than in younger people. This tends to make drugs more potent in older people. For example, the loss of liver enzymes means that an individual 70 years old will get the same effect from 10 milligrams of Valium as a 21-year-old taking a 30 milligram dosage. Sorry, got the hiccups. And I'm 73. The most frequently abused drugs after alcohol for the elderly are Vicodin, narcotic cough syrup, Darvon and other opioid analgesics, prescription sedatives such as Klonopin, over-the-counter sedatives, over-the-counter sleep aids, Prozac, Zoloft, and Buspar. While not everyone takes their medications in the prescribed manner, the elderly tend to have more problems than others, and this may have to do with memory. Overuse, taking more or many different types of drugs than prescribed. Underuse, failing to take appropriately prescribed drugs or the correct dosage. Erratic use, failure to take drugs in the right dosage or at the right time. Contraindicated use, incorrect drug being used, causing an adverse reaction or drug inactivity. Abuse and addiction, using drugs for non-medical purposes despite negative consequences. Common drugs abused by elders: nicotine, 94% of all 430,000 premature deaths from smoking are in people over 50. Tobacco's effects are actually more pronounced in the elderly because of their inability to clear toxins as they did when they were younger. Elderly smokers have twice the mortality risk of cardiovascular disease than non-smoking elders. Caffeine, the average consumption of caffeine for the elderly is 200 milligrams. That's 2 cups of brewed coffee. Caffeine toxicity can be seen at doses as low as 100 milligrams. When seniors use excessive caffeine, it can lead to loss of bone density, increasing the possibility of hip fractures. The most prevalent problem among the elderly is alcohol. 6 to 11% of elderly hospital admittance show signs of alcoholism. ER visits find 14% of the elderly seen show signs of alcoholism. 20% of the elderly in psychiatric wards are alcoholic. 49% of the elderly in nursing homes are alcoholic. Because the presenting medical problems, alcoholism is often overlooked by medical personnel. Alcohol affects the elderly so much more seriously than the younger individual because less efficiency of the liver, decrease in body water, increase in sensitivity to alcohol, decrease in tolerance to alcohol, a decrease in the metabolism of alcohol in the gastrointestinal tract. Lower amounts of alcohol will lead to intoxication for the elderly. Over-the-counter medications can cause the elderly problems. Sedatives can contain antihistamines for their sedating effect, and the liquid forms have more alcohol than wine. Insom, Sleepies, Nitol, and Sominex are example of sedatives that you take to fall asleep. Cold medications will contain the same combination of alcohol and antihistamines. Abuse of prescription drugs has been reported as low as 5% and as high as 33% in the elderly. This occurs even in extended care facilities. Benzodiazepines are used by 71% of the elderly between 50 and 65, and 33% of those over 65. These drugs can cause confusion and falls. Abuse of prescription opioid and analgesics has increased by 500% since 1990. That's OxyContin and hydrocodone. Hydrocodone comes in different forms, Norco, Lortab, and Vicodin. While few think of the elderly as drug abusers, of the total hospital admissions for the elderly, 20% are directly due to prescription or over-the-counter drug reactions exclusive of alcohol and illicit drug admissions. 20% of the elderly are regular drinkers and continue to extend controllable amounts, 12% of men and 2% of women. 80% of the senior arrests are for drunkenness. Primary prevention for the elderly need to be educated as to the changing effects of alcohol and drugs as they get older and the increased dangers of excessive use. Secondary prevention with this age group involves recognizing the early stages of alcohol and drug addiction and appropriate intervention tactics. Tertiary prevention, treatment for the elderly, involves a slower pace of therapy focusing on patience and reassurance. And that is finally the end of the chapter. So I'll talk to you next week.